Hi, I am Sung-Hye, the first author of this study. In this presentation, I'd like to talk about the synthetic TOF-MRA generation model based on the Cycle-GAN using the PETRA-MRA in the patient with treated intracranial aneurysm. Before starting the main part of this presentation, I want to show the two representative cases which made us to be interested in PETRA-MRA. This is the case of the unobserved left dorsal wall aneurysm. We performed the coil embolization for this aneurysm, and during the procedure, microcardial was kicked back and inserted coil loop was retracted to the parent vessel. So we placed the rescue stent for preventing the prolapse of the coil loop. After 2 days, we performed the follow-up TOF-MRA, but we could not evaluate the instant oral residual flow due to the susceptibility artifact and RF shielding effect of the stent. It is well-known limitation of TOF-MRA. However, in PETRA, both instant and residual flow were well demonstrated. This is another case we performed the simple coiling for the ACOM aneurysm and the small leg remnant remained. That was demonstrated well in PETRA but not in TOF-MRA. PETRA is the name of commercial UT sequence in GMAS. In this regard, we were interested in UT-MRI and have been performing a few studies about this sequence. PETRA was developed based on the UT method. Central case space is filled by Pointwise encoding and the outer case space is filled by radial acquisition. So it has several unique strengths like this. Visualization of ultra-short materials minimize the susceptibility artifact, quiet imaging from the minimal gradient change, and the low motion artifact from the radial acquisition. Under this background, we recently reported the usefulness of PETRA-MRA in the patient with treated intracranial aneurysm. We performed PETRA, TOF, and CMRA simultaneously for the 128 patients who underwent simple coiling and 61 patients who underwent the stent-assisted coiling. T was 0.07 millisecond, total acquisition time was 6 minutes 40 seconds, and we used the 30,000 radial spokes. In this study, sensitivity of PETRA in detection of residual flow is significantly superior to that of TOF in simple coiling and stent-assisted coiling. As you can see, residual flow are well demonstrated in PETRA. There was no significant difference in size of residual flow between PETRA and DSA. In the stent-assisted coiling, the visualization of instant flow via the PETRA was superior to that via the TOF. PETRA-MRA overcomes the critical limitation of TOF-MRA in evaluating aneurysm recurrence. However, UT-MRA cannot replace the TOF-MRA as a follow-up protocol for treated aneurysm because of its background residual artifact and low peripheral SNR. UT-MRA is a subtraction-based ASL-MRA technique using a two data set of non-saturated and saturated images acquired using saturation slabs. Severe background noise and image blurring develop even with a minor motion in UT-MRA if the patient cannot tolerate relatively long scan time of UT-MRA. So for 3 years, we performed PETRA and TOF simultaneously for patients with treated aneurysm. The total acquisition time for both sequences was approximately 12 minutes even we used only 30,000 spokes. So we wanted to improve the overall PETRA image qualities not to require the TOF images because reducing total acquisition time is important in MRI. Recently, the role of deep learning in medical imaging is expanding from detection and diagnosis to improving the image qualities. Last year, these two studies regarding the image quality improvement was published in Radiology. Image quality improvement is important in aspect of dose reduction in CT and scan time reduction in MRI. In the line of this trend, GAN has attractive attention in field of image quality improvement and image transfer. In this deep learning algorithm, there are two neural networks, generator and discriminator. The generator generates the realistic images to confuse the discriminator, and the discriminator recognizes whether the generated images are real or fake. So the aim of GAN is at generating fake realistic looking images. In 2014, GAN was invented by Angiography, and in medical imaging, the first clinical application of this model was cardiac CT denoising in 2017. After that, until 2020, 33 studies using GAN in medical imaging have been published. These four topics are the main categories of the study, and denoising is the most actively evaluated. Using input data, usually low-quality images, generator generated the fake image expected to resemble real high-quality images. Then the discriminator determined a probability for the imaging being real. Using the output from the discriminator, the generator adapted its parameters to improve the generated images. All these pathways have been aimed at minimizing the loss function. One of the important limitations of GAN is that there is a risk that neural network may generate the features that are not present in the images or generate the same images regardless of its input due to the potential mode collapse behavior of the GAN. Under this background, we try to generate the synthetic TOF which has higher overall image qualities than that of PETRA. We started the study with 377 patients who underwent both PETRA and TOF-MRA simultaneously. The data from 188 patients were used for model development, and that from the 189 patients was used for the image quality validation. In training stage, we used a modified Cycle-GAN consisted with 2 generators, 2 discriminators, 4 types of loss function, and grad cam. Validation stage, using this generator, we generate the synthetic TOF from PETRA in validation dataset, and then we perform the qualitative and quantitative analysis for PETRA, synthetic TOF, and real TOF. And then we conducted multi-observer image quality assessment with 17 radiologists for the randomly selected 12 patients. In qualitative analysis based on the 5-point recurrence scale, overall image quality, noise, sharpness, and vascular conspicuity were improved in synthetic TOF. In the quantitative analysis, SNR was increased in synthetic TOF. It was even higher than true TOF. We presume that it was from the effective denoising. In the multi-observer imaging quality assessment, there was no significant difference in the question for the diagnostic optimality and image preference between the synthetic TOF and real TOF. Also, for the question to choose the real TOF, the readers could not differentiate the synthetic TOF from the real TOF. Although there was a positive correlation between the radiologic experience and to choose the real TOF. This is the synthetic TOF. It shows the comparable image qualities with the TOF. The more details of our study are in this paper, and I hope that this work is meaningful for the application of PETRA-MRA and cycle-GAN for medical imaging. Thank you so much for listening, and if you have any question about this study, don't hesitate to contact us. Thank you.